Question 1. System analysis indicates that a 45-year-old male sustained a severe traumatic brain injury, TBI, 3 months ago, resulting in persistent spasticity and significant motor deficits. His family, acting as his surrogate decision-makers, are seeking options to improve his functional recovery. The medical team is considering initiating baclofen, a muscle relaxant, to manage his spasticity. However, the surrogate expresses significant anxiety about potential side effects, including sedation and cognitive impairment, which they fear could further hinder the patient's progress and quality of life. The patient himself is unable to participate in the decision-making process due to his cognitive deficits. Which of the following approaches best represents the appropriate management strategy in this ethically complex situation? Adhering to U.S. regulatory and ethical guidelines for patient care and surrogate decision-making. Option A. Prescribe the maximum therapeutic dose of baclofen immediately to achieve the most rapid reduction in spasticity, assuming the benefits will outweigh any potential side effects. Option B. Initiate baclofen at a low dose and titrate slowly, while closely monitoring for efficacy and side effects, and engaging in ongoing dialogue with the surrogate about their concerns and the patient's response. Option C. Defer the initiation of baclofen indefinitely due to the surrogate's expressed concerns about side effects, opting instead to rely solely on physical and occupational therapy. Option D. Proceed with baclofen treatment without further detailed discussion with the surrogate, as the medical team has determined it is the most appropriate intervention based on clinical guidelines. The correct answer is B. Initiate baclofen at a low dose and titrate slowly, while closely monitoring for efficacy and side effects, and engaging in ongoing dialogue with the surrogate about their concerns and the patient's response. Explanation. This scenario presents a professional challenge due to the inherent uncertainty in predicting individual responses to pharmacological interventions for brain injury, coupled with the ethical imperative to balance potential benefits against risks, especially when a patient's capacity to consent is compromised. The physician must navigate the complexities of evidence-based practice, patient autonomy, or surrogate decision-making, and the potential for adverse drug reactions or treatment ineffectiveness. The correct approach represents best professional practice by prioritizing a shared decision-making process, even with a surrogate. This aligns with the ethical principles of beneficence, acting in the patient's best interest, and respect for autonomy, even if exercised by a surrogate. The physician's role is to provide comprehensive information about the risks, benefits, and alternatives, allowing the surrogate to make an informed decision that reflects the patient's known values and preferences, or what is deemed to be in their best interest. This process is supported by guidelines on informed consent and surrogate decision-making, which are fundamental to medical practice in the United States. An incorrect approach that involves unilaterally initiating a high-risk medication without thorough discussion with the surrogate fails to uphold the principle of informed consent and surrogate decision-making. This constitutes an ethical failure by potentially disregarding the patient's values and preferences, which the surrogate is legally and ethically empowered to represent. It also risks alienating the surrogate and eroding trust, which is crucial for ongoing care. Another incorrect approach, delaying treatment indefinitely due to fear of side effects without a clear plan for reassessment or alternative management, could be considered a failure of beneficence. Caution is warranted. A complete lack of intervention when a potentially beneficial treatment exists without a justifiable reason may not be in the patient's best interest. This could also be seen as a failure to adhere to standards of care if evidence supports the use of such medications in similar clinical presentations. A third incorrect approach, focusing solely on the most aggressive pharmacological intervention without considering the patient's overall clinical picture, functional status, and potential for non-pharmacological interventions, demonstrates a lack of holistic patient care. This can lead to iatrogenic harm and may not address the underlying issues contributing to the patient's symptoms. It neglects the principle of proportionality, where the intensity of intervention should match the severity and nature of the condition. The professional decision-making process for similar situations should involve a systematic assessment of the patient's condition, a thorough review of the evidence for potential pharmacological interventions, and an open, transparent discussion with the patient, if capable, or their designated surrogate. This discussion should cover the rationale for treatment, expected outcomes, potential side effects, and alternative management strategies. Documentation of this process, including the surrogate's understanding and decision, is critical. Question 2. Research into the management of individuals with moderate to severe traumatic brain injury reveals a high prevalence of comorbid psychiatric disorders. A patient presents with new-onset irritability, significant sleep disturbance, and a pervasive sense of hopelessness following a recent frontal lobe contusion. Which of the following assessment strategies best aligns with the American Board of Psychiatry and Neurology's guidelines for the subspecialty in brain injury medicine in evaluating this patient's presentation? Option A. Rely solely on the patient's self-reported symptoms of hopelessness, assuming it is a direct and uncomplicated manifestation of their frontal lobe injury. Option B. Conduct a comprehensive psychiatric interview, administer validated screening tools for depression and anxiety, and obtain collateral information from the patient's spouse regarding behavioral changes and functional impact. Option C. Focus exclusively on neurocognitive testing to identify deficits related to the frontal lobe contusion, deferring any formal psychiatric assessment until cognitive recovery is complete. Option D. Interpret all reported symptoms, including irritability and sleep disturbance, as purely psychological reactions to the trauma, without considering their potential neurobiological origins or the need for specific psychiatric evaluation. The correct answer is B. Conduct a comprehensive psychiatric interview, administer validated screening tools for depression and anxiety, and obtain collateral information from the patient's spouse regarding behavioral changes and functional impact. Explanation: this scenario is professionally challenging because the assessment of comorbid psychiatric disorders in individuals with brain injury requires a nuanced understanding of how the neurological insult can manifest as or exacerbate psychiatric symptoms, making differential diagnosis difficult. Clinicians must navigate the complexities of distinguishing primary psychiatric conditions from secondary symptoms of brain injury, while also considering the impact of cognitive deficits on the patient's ability to report symptoms accurately. Adherence to the American Board of Psychiatry and Neurology (ABPN) guidelines for brain injury medicine is paramount, ensuring that diagnostic and treatment approaches are evidence-based and patient-centered. The correct approach represents best professional practice by prioritizing a comprehensive, multimodal assessment that integrates neurocognitive evaluation with psychiatric screening. This aligns with ABPN standards, which emphasize a holistic approach to brain injury management, recognizing the interconnectedness of neurological and psychiatric health. Utilizing validated screening tools, obtaining collateral information from caregivers, and conducting a thorough clinical interview are essential components of accurate diagnosis and effective treatment planning, directly supporting the ABPN commitment to high-quality patient care in brain injury medicine. An incorrect approach that relies solely on self-report without considering the potential impact of cognitive impairment on symptom reporting fails to meet the standards of care for brain injury patients. This can lead to misdiagnosis and inappropriate treatment, as the patient may not be able to accurately articulate their internal experiences due to executive dysfunction, memory deficits, or anosognosia, all common sequelae of brain injury. Such an approach would violate the ethical principle of beneficence by potentially leading to ineffective or harmful interventions. Another incorrect approach that focuses exclusively on a single psychiatric symptom without exploring its potential neurobiological underpinnings neglects the core principles of brain injury medicine. Brain injury can directly cause or mimic a wide range of psychiatric symptoms, including depression, anxiety, irritability, and psychosis. Failing to consider the brain injury as a potential etiology or contributing factor to the psychiatric presentation is a significant diagnostic error and a failure to adhere to the specialized knowledge expected of a brain injury medicine subspecialist. This approach risks overlooking crucial aspects of the patient's condition and developing an incomplete or inaccurate treatment plan. A third incorrect approach that dismisses the patient's reported psychiatric symptoms as solely a consequence of the brain injury, without a formal psychiatric evaluation, is also professionally unacceptable. While it is true that brain injury can cause psychiatric symptoms, it does not preclude the presence of a co-occurring primary psychiatric disorder. A thorough differential diagnosis is required to identify all contributing factors to the patient's distress and functional impairment. Failing to conduct a comprehensive psychiatric assessment can lead to undertreatment of a primary psychiatric condition which can significantly impact recovery and quality of life. This represents a failure to provide comprehensive care as expected within the scope of brain injury medicine. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly understand the patient's neurological injury and its known sequelae. Second, conduct a comprehensive psychiatric assessment, utilizing validated tools and considering the impact of cognitive deficits on symptom reporting. Third, gather collateral information from reliable sources. Fourth, develop a differential diagnosis that considers both primary psychiatric disorders and psychiatric symptoms secondary to brain injury. Finally, formulate an integrated treatment plan that addresses all identified conditions, prioritizing evidence-based interventions and patient-centered goals in accordance with APBIN guidelines. Question 3. The audit findings indicate a discrepancy in the management of a patient with a severe traumatic brain injury. The patient, who is now ventilator-dependent and in a persistent vegetative state, previously executed a valid advance directive clearly stating a desire to refuse all life-sustaining treatments, including mechanical ventilation, should they become permanently unconscious or unable to communicate. However, the patient's family is now expressing significant distress and is requesting that all possible measures be taken to maintain the patient's life, citing a belief that the patient would want to fight for survival. The attending physician is uncertain how to proceed, balancing the patient's documented wishes against the family's current emotional pleas and the potential for future, albeit uncertain, recovery. Which of the following represents the most appropriate course of action for the physician in this ethically complex situation, adhering to U.S. regulatory and ethical frameworks for brain injury medicine? Option A. Initiate a comprehensive multidisciplinary assessment to evaluate the patient's current prognosis, capacity, and the validity of the advance directive in light of the current clinical presentation, while simultaneously engaging in open communication with the family and seeking ethics committee consultation. Option B. Immediately discontinue mechanical ventilation as per the patient's advance directive, informing the family of the legal and ethical obligation to honor such documents. Option C. Continue aggressive life-sustaining treatment, overriding the advance directive based on the family's current wishes and the physician's assessment of the patient's potential for survival, without further consultation. Option D. Defer the decision indefinitely, continuing all current medical interventions while the family processes their grief and the physician gathers more information, without a defined timeline for resolution. Correct answer is B. Immediately discontinue mechanical ventilation as per the patient's advance directive, informing the family of the legal and ethical obligation to honor such documents. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from a discrepancy between a patient's documented wishes and the current clinical presentation following a severe brain injury. The physician is faced with a conflict between respecting patient autonomy, as expressed prior to incapacitation, and the potential for the patient to experience suffering or have their quality of life diminished if life-sustaining treatment is withdrawn based solely on an advance directive that may not fully capture the nuances of their current state or potential for recovery. The ethical imperative to act in the patient's best interest, while also upholding their right to self-determination, requires careful consideration and a structured decision-making process. Correct approach analysis. The correct approach involves a comprehensive, multidisciplinary assessment to determine the patient's current prognosis and capacity, alongside a thorough review of the advance directive and consultation with surrogate decision-makers. This aligns with the ethical principles of beneficence, acting in the patient's best interest, non-maleficence, avoiding harm, and respect for autonomy. In the context of U.S. healthcare law and ethical guidelines governing brain injury medicine, the physician has a duty to explore all reasonable avenues to ascertain the patient's wishes and current condition before making a decision that could lead to the withdrawal of life-sustaining treatment. This includes engaging in open communication with the family or designated surrogate, reviewing all available medical information, and potentially seeking ethics committee consultation. The APBIN Subspecialty in Brain Injury Medicine exam emphasizes the physician's role in navigating complex ethical landscapes, and this approach demonstrates a commitment to patient-centered care and adherence to established medical ethics. Incorrect approaches analysis. One incorrect approach involves immediately honoring the advance directive without further assessment or discussion. This fails to acknowledge that advance directives are expressions of past wishes and may not fully account for the patient's current medical reality or potential for recovery, which can be highly variable in brain injury. Ethically, this could lead to a failure of beneficence if the patient's condition has improved or if the directive was made under circumstances that are no longer relevant. Legally, while advance directives are powerful, their interpretation in complex medical situations often requires careful consideration of the patient's best interests and current capacity. Another incorrect approach is to disregard the advance directive entirely and proceed with aggressive life-sustaining treatment based solely on the physician's judgment of the patient's best interest, without adequate consultation or consideration of the patient's prior expressed wishes. This represents a significant ethical failure in respecting patient autonomy. While beneficence is a guiding principle, it cannot override a patient's legally recognized right to refuse or direct medical treatment, even if that treatment is life-sustaining. This approach also risks alienating the family or surrogate decision-makers, potentially leading to legal challenges and undermining trust in the healthcare system. A third incorrect approach is to delay decision-making indefinitely due to the complexity of the situation, leading to prolonged and potentially futile treatment. While caution is warranted, prolonged indecision can also be detrimental, potentially leading to increased patient suffering and resource utilization without a clear benefit. Ethically, this can be seen as a failure of non-maleficence if the continued treatment is causing harm or distress. Professional decision-making requires timely and informed choices, even in challenging circumstances. Professional reasoning. When faced with such a dilemma, the professional decision-making process should involve 1. Thoroughly reviewing the patient's medical history, including the advance directive, and understanding the specific nature and severity of the brain injury. 2. Engaging in open and empathetic communication with the patient's family or designated surrogate to gather information about the patient's values, beliefs, and prior discussions regarding end-of-life care. 3. Conducting a comprehensive multidisciplinary assessment of the patient's current neurological status, prognosis, and potential for meaningful recovery, involving specialists as needed. 4. Consulting with the hospital's ethics committee or a similar consultative body to gain diverse perspectives and guidance on navigating the ethical complexities. 5. Documenting all discussions, assessments, and decisions meticulously. This systematic approach ensures that all relevant ethical and clinical factors are considered, promoting patient-centered care and adherence to professional standards. Question 4. Quality control measures reveal a pattern of delayed recognition and management of escalating intracranial pressure, in patients admitted with severe traumatic brain injury, TBI, to a neurocritical care unit. Specifically, the data suggests that while initial ICP monitoring is initiated, subsequent interventions to address secondary injury processes such as cerebral edema and ischemia are often reactive rather than proactive, and the integration of neuroimaging findings into immediate treatment adjustments is inconsistent. This leads to prolonged periods of elevated ICP and suboptimal cerebral perfusion pressure in a significant subset of patients. Which of the following approaches best addresses this quality control finding and aligns with best practices for managing secondary injury processes in TBI? Option A. Prioritize the use of aggressive hyperventilation in all patients with elevated ICP to rapidly reduce cerebral blood flow and ICP, as this has historically been a cornerstone of TBI management. Option B. Focus on optimizing sedation and analgesia to reduce metabolic demand and minimize patient agitation, as this is the primary driver of elevated ICP in the acute phase of TBI. Option C. Emphasize physician education on the pathophysiology of secondary injury processes, encouraging individual clinical judgment in response to ICP monitoring data without a rigid protocol, relying on the expertise of experienced intensivists to guide treatment decisions. Option D. Implement a standardized, multidisciplinary protocol for the management of severe TBI that includes continuous ICP monitoring, regular neuroimaging review for evidence of edema and ischemia, and predefined tiered interventions for managing elevated ICP and ensuring adequate cerebral perfusion pressure, with clear triggers for escalation of care and consultation. The correct answer is D. Implement a standardized, multidisciplinary protocol for the management of severe TBI that includes continuous ICP monitoring, regular neuroimaging review for evidence of edema and ischemia, and predefined tiered interventions for managing elevated ICP and ensuring adequate cerebral perfusion pressure, with clear triggers for escalation of care and consultation. Explanation: this scenario presents a common challenge in brain injury medicine: the timely and accurate identification and management of secondary injury processes, specifically ischemia, edema, and inflammation, following a traumatic brain injury, TBI. The professional challenge lies in the dynamic nature of these processes, which can evolve rapidly and significantly impact neurological outcomes. Effective management requires a nuanced understanding of pathophysiology, vigilant monitoring, and the judicious application of evidence-based interventions, all within the framework of established clinical guidelines and ethical practice. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based, and multidisciplinary strategy for managing secondary injury. This involves continuous neurological assessment, utilization of advanced neuroimaging to detect and quantify secondary insults, and the implementation of targeted therapies aimed at mitigating ischemia, e.g., maintaining adequate cerebral perfusion pressure, reducing edema, e.g., osmotic therapy, head elevation, and controlling inflammation, e.g., judicious use of corticosteroids if indicated by specific guidelines, though this is a complex area with evolving evidence. Adherence to established protocols and guidelines, such as those from the Brain Trauma Foundation, ensures that care is delivered in a manner consistent with current scientific understanding and promotes optimal patient recovery. This approach aligns with the APBIN commitment to ensuring subspecialists possess the knowledge and skills to manage complex neurological conditions effectively and ethically. An incorrect approach that focuses solely on symptomatic treatment without addressing the underlying secondary injury mechanisms is professionally unacceptable. This failure to identify and manage ischemia, edema, or inflammation directly contravenes the core principles of TBI management and can lead to irreversible neurological damage. Such an approach may also violate ethical obligations to provide comprehensive and evidence-based care, potentially leading to suboptimal outcomes and increased patient morbidity. Another incorrect approach that relies on outdated or unproven therapies, or that delays essential diagnostic interventions like serial imaging, represents a failure to adhere to current best practices and evidence-based medicine. This can result in missed opportunities to intervene effectively, thereby increasing the risk of secondary injury progression and negative outcomes. This also falls short of the professional responsibility to stay abreast of evolving medical knowledge and to apply it judiciously. Finally, an approach that neglects the multidisciplinary nature of TBI care, failing to involve specialists in neurocritical care, neurosurgery, and rehabilitation, is also professionally deficient. Effective management of secondary injury requires coordinated efforts from various disciplines to address the multifaceted needs of the patient. A siloed approach can lead to fragmented care and missed opportunities for synergistic interventions. A professional decision-making process for similar situations should involve a rapid assessment of the patient's neurological status, immediate consideration of potential secondary injury processes, and prompt initiation of diagnostic and therapeutic interventions guided by established protocols and expert consultation. Continuous reevaluation and adaptation of the treatment plan based on the patient's response and evolving clinical picture are paramount. Question 5. Which approach would be most appropriate for a rehabilitation team to comprehensively assess the functional status of a patient recovering from a moderate traumatic brain injury, aiming to guide individualized treatment planning and track progress for reporting purposes within the U.S. healthcare system? Option A. Employing a validated, multidimensional functional assessment tool that evaluates a broad spectrum of activities of daily living, instrumental activities of daily living, and community reintegration skills. Option B. Utilizing a specialized cognitive screening tool that focuses exclusively on attention and memory deficits. Option C. Administering a functional assessment tool primarily designed for patients with spinal cord injuries without considering its applicability to brain injury. Option D. Relying solely on informal clinical observations and subjective reports from the patient and family regarding perceived functional abilities. The correct answer is A. Employing a validated, multidimensional functional assessment tool that evaluates a broad spectrum of activities of daily living, instrumental activities of daily living, and community reintegration skills. Explanation. This scenario presents a common challenge in brain injury medicine, selecting the most appropriate functional assessment tool to guide rehabilitation planning and track progress. The professional challenge lies in the nuanced differences between available tools and the need to align the chosen instrument with the specific goals of patient care, the rehabilitation setting, and the requirements for reporting and reimbursement, all within the framework of U.S. healthcare regulations and APN examination standards. Careful judgment is required to ensure the assessment is valid, reliable, and clinically meaningful. The correct approach represents best professional practice because it prioritizes a comprehensive, multidimensional assessment that captures a wide range of functional abilities relevant to daily living and community reintegration. This aligns with the principles of patient-centered care and the need for robust data to inform individualized treatment plans. The use of a tool like the Functional Independence Measure, FIM, or the Functional Assessment Measure, FAM, which are widely recognized and validated in the U.S. for assessing functional status after neurological injury, provides a standardized and objective measure of a patient's ability to perform activities of daily living and their need for assistance. This data is crucial for demonstrating progress, justifying continued therapy, and meeting the requirements of payers and regulatory bodies like CMS, which often rely on such standardized assessment for reimbursement decisions. An incorrect approach that focuses solely on a single domain of function, such as motor skills, fails to capture the holistic impact of brain injury on a patient's life. This is professionally unacceptable because it provides an incomplete picture of the patient's needs and capabilities, potentially leading to suboptimal rehabilitation goals and interventions. Ethically, it violates the principle of beneficence by not fully addressing all aspects of the patient's well-being. From a regulatory standpoint, such a narrow assessment may not meet the documentation requirements for payers or accrediting bodies, potentially leading to reimbursement denials or compliance issues. Another incorrect approach that relies on informal observation without standardized tools is professionally unacceptable due to its inherent subjectivity and lack of reliability. While clinical observation is vital, it must be supplemented by validated instruments to ensure objectivity and comparability of data over time and across different clinicians. This approach risks bias and may not provide the quantifiable data necessary for evidence-based decision-making or for meeting external reporting mandates. Regulatory failures would include a lack of objective evidence to support treatment decisions or progress claims, potentially impacting audits and quality reviews. A third incorrect approach that exclusively uses a tool designed for a different patient population, such as a purely cognitive assessment without functional components, is professionally unacceptable because it is not validated for the specific context of brain injury rehabilitation. Using an inappropriate tool can lead to misinterpretation of results, inaccurate goal setting, and ultimately, ineffective treatment. This represents a failure to adhere to best practices in assessment selection and can have ethical implications if it leads to misdiagnosis or inappropriate care planning. Regulatory issues could arise if the chosen assessment does not meet the standards for documenting functional status for reimbursement or quality reporting purposes. The professional reasoning process for similar situations should involve a systematic evaluation of the patient's specific needs, the goals of the rehabilitation program, and the requirements of the clinical setting. This includes understanding the psychometric properties of various assessment tools, their applicability to the brain injury population, and their alignment with regulatory and payer expectations. Clinicians should consult evidence-based guidelines and consider the multidimensional nature of functional recovery after brain injury, selecting tools that provide a comprehensive and objective measure of a patient's abilities and limitations. Question 6. The review process indicates a discrepancy in how genetic factors influencing recovery and outcomes are being integrated into patient management plans for individuals with acquired brain injury. A clinician is presented with a patient who has sustained a moderate traumatic brain injury and has a family history suggestive of certain genetic polymorphisms known to be associated with slower cognitive recovery in some studies. The clinician needs to determine the most appropriate approach to incorporate this information into the patient's care plan, balancing scientific evidence with clinical realities and ethical considerations. Which of the following approaches best reflects current best practices in brain injury medicine, considering the complexities of genetic influences on recovery? Option A. Order extensive genetic sequencing for all potential genes related to neurological recovery and use the results to create a highly detailed, personalized rehabilitation plan, irrespective of the patient's current clinical status or functional abilities. Option B. Recommend genetic testing for the specific polymorphisms and base the entire long-term rehabilitation prognosis and resource allocation solely on the predicted recovery trajectory derived from these genetic results. Option C. Acknowledge the family history of genetic polymorphisms, but emphasize that current evidence is insufficient to definitively predict individual recovery outcomes, and proceed with a comprehensive, multidisciplinary assessment and individualized rehabilitation plan based on clinical presentation, injury severity, and patient-specific factors, while keeping genetic research in mind for future considerations. Option D. Inform the patient and family that their genetic predisposition guarantees a specific level of recovery, leading to either an overly optimistic or pessimistic outlook, and adjust the rehabilitation intensity accordingly without further clinical evaluation. The correct answer is B. Recommend genetic testing for the specific polymorphisms and base the entire long-term rehabilitation prognosis and resource allocation solely on the predicted recovery trajectory derived from these genetic results. Explanation. The review process indicates a common challenge in brain injury medicine, translating complex genetic research into actionable clinical practice for individual patient care. The professional challenge lies in balancing the emerging understanding of genetic predispositions and their influence on recovery trajectories with the current limitations in predictive accuracy and the ethical implications of genetic information. Clinicians must navigate the uncertainty inherent in genetic research, avoid over-reliance on probabilistic data, and ensure that patient care remains individualized and evidence-based, adhering to the principles of informed consent and avoiding genetic determinism. The correct approach represents best professional practice by prioritizing a comprehensive, multidisciplinary assessment that integrates genetic information as one component among many. This aligns with the American Board of Psychiatry and Neurology's emphasis on holistic patient evaluation and evidence-based medicine. It acknowledges that while genetic factors can play a role, they do not solely dictate outcomes. This approach respects patient autonomy by ensuring that genetic findings are discussed within the broader context of prognosis, treatment options, and patient values, facilitating shared decision-making. It also adheres to ethical guidelines regarding the responsible use of genetic information in clinical settings, avoiding premature conclusions or stigmatization. An incorrect approach that focuses solely on genetic markers for predicting recovery would be a significant regulatory and ethical failure. It oversimplifies a complex biological process and risks violating the principle of individualized care. Such an approach could lead to inappropriate resource allocation, false hope or despair for patients and families, and potential discrimination based on genetic predispositions, which is contrary to the spirit of patient-centered care and the ethical obligations of medical professionals. Another incorrect approach that relies exclusively on traditional clinical assessments without considering emerging genetic research would also be professionally suboptimal. While adhering to established protocols, it fails to incorporate potentially valuable, albeit still developing, scientific insights that could enhance prognostic accuracy and personalized treatment strategies. This could lead to missed opportunities for optimizing patient care and could be seen as a failure to stay abreast of advancements in the field, which is an implicit expectation for subspecialists. A third incorrect approach that involves disclosing genetic findings without adequate counseling or contextualization is ethically problematic. Genetic information can be highly sensitive and complex. Failing to provide appropriate genetic counseling can lead to patient distress, misinterpretation of results, and a failure to achieve informed consent for subsequent management decisions. This violates the ethical duty to ensure patients understand the implications of their medical information. The professional reasoning process for similar situations should involve a thorough review of the available evidence, including both established clinical predictors and emerging genetic research. Clinicians must critically evaluate the strength of evidence for genetic influences on recovery in specific injury types and patient populations. They should engage in ongoing professional development to stay current with genetic research. When considering genetic testing or discussing genetic findings, a multidisciplinary team approach, including genetic counselors, is often advisable. Crucially, All discussions with patients and families must emphasize that genetic factors are just one piece of a complex puzzle, and that individual responses to injury and rehabilitation are multifactorial. Shared decision-making, grounded in clear communication and respect for patient values, must be the cornerstone of care. Question 7. The analysis reveals a 35-year-old male presenting to the emergency department following a motor vehicle accident. He reports a brief period of disorientation and a headache immediately after the impact, with no reported loss of consciousness. On examination, he is alert and oriented, with no focal neurological deficits. Initial CT scan of the head shows no evidence of intracranial hemorrhage or contusion. Given this presentation, which of the following diagnostic considerations best reflects the initial assessment of his brain injury? Option A. A functional disturbance of brain function, such as a concussion, is the primary consideration, with close monitoring for any evolving neurological deficits. Option B. A focal brain contusion should be strongly suspected due to the mechanism of injury, regardless of the initial CT findings. Option C. The presence of disorientation, even if transient, necessitates immediate advanced neuroimaging techniques to detect subtle axonal shearing indicative of diffuse axonal injury. Option D. The absence of loss of consciousness and normal initial CT scan definitively rules out any significant structural brain injury, including diffuse axonal injury. Correct answer is A. A functional disturbance of brain function, such as a concussion, is the primary consideration, with close monitoring for any evolving neurological deficits. Explanation. Scenario analysis. This scenario presents a professionally challenging situation due to the potential for subtle yet significant differences in the underlying pathophysiology of brain injuries, even when initial symptoms appear similar. Differentiating between concussion, contusion, and diffuse axonal injury, DI, is critical for accurate prognosis, appropriate management, and effective communication with patients and their families. Misclassification can lead to underestimation or overestimation of severity, impacting rehabilitation strategies and long-term outcomes. The challenge lies in integrating clinical presentation, neuroimaging findings, and the temporal course of symptoms to arrive at the most precise diagnosis. Correct approach analysis. The correct approach involves a comprehensive assessment that integrates multiple data points to differentiate the specific type of brain injury. This aligns with the American Board of Psychiatry and Neurology's emphasis on thorough diagnostic evaluation and evidence-based practice. A concussion, by definition, is a functional disturbance rather than a structural injury, often characterized by transient neurological deficits. A contusion represents a focal bruise on the brain, typically visible on imaging. Diffuse axonal injury, DI, involves widespread shearing of axons, which may not be immediately apparent on standard imaging, but can lead to severe and prolonged neurological deficits. Therefore, a systematic approach considering the mechanism of injury, clinical presentation, and neuroimaging findings is essential for accurate diagnosis and appropriate patient care. Reflecting best professional practice. Incorrect approach is analysis. One incorrect approach would be to solely rely on the initial presentation of transient confusion and headache to diagnose a concussion without further investigation. This fails to adequately consider the possibility of underlying structural damage, such as a contusion or DAI, which may present with similar initial symptoms, but have significantly different prognoses and management needs. This approach risks underestimating the severity of the injury and delaying appropriate interventions, potentially violating ethical obligations to provide comprehensive care. Another incorrect approach would be to immediately assume a severe injury like DAI based on any loss of consciousness, without considering the nuances of clinical presentation and imaging. While loss of consciousness can be a marker of severity, it is not pathognomonic for DAI. Overdiagnosing DAI without sufficient evidence can lead to unnecessary patient anxiety and potentially inappropriate, overly aggressive management strategies, deviating from evidence-based practice. A third incorrect approach would be to focus exclusively on neuroimaging findings without correlating them with the clinical presentation. For instance, subtle findings on imaging might be misinterpreted in the absence of a clear clinical correlate, or conversely, a significant clinical deficit might be overlooked if imaging appears relatively unremarkable, as can be the case in early stages of DAI. This siloed approach neglects the holistic understanding required for accurate diagnosis and patient management. Professional reasoning. professionals should employ a systematic diagnostic framework that begins with a detailed history of the injury mechanism and the patient's symptoms. This is followed by a thorough neurological examination. Neuroimaging, including CT or MRI, should be utilized judiciously to identify or rule out structural lesions such as contusions or evidence suggestive of DAI. The temporal evolution of symptoms is also a crucial factor. By integrating these elements, clinicians can differentiate between functional disturbances, concussion, and structural injuries, contusion, DAI, ensuring that patient care is tailored to the specific diagnosis and its implications for recovery and rehabilitation. This systematic approach is fundamental to providing competent and ethical care within the scope of brain injury medicine. Question 8. Cost-benefit analysis shows that a comprehensive, multimodal assessment strategy for identifying substance use disorders in patients with brain injury is more effective in the long term for patient recovery and reducing healthcare utilization. Considering the unique challenges posed by cognitive deficits and potential impaired insight following brain injury, which of the following assessment approaches best aligns with current best practices and ethical considerations for this patient population? Option A. Employing direct, confrontational questioning about substance use, immediately linking any positive disclosure to potential legal or social consequences to ensure honesty. Option B. Focusing solely on the neurological examination and neuroimaging findings to attribute all behavioral and cognitive changes to the brain injury, without actively screening for substance use. Option C. Relying exclusively on the patient's self-report of substance use, assuming that cognitive deficits do not significantly impact their ability to accurately recall or disclose their history. Option D. Implementing a structured clinical interview that incorporates validated screening tools for substance use disorders, supplemented by collateral information from family or caregivers, with patient consent, and consideration of objective biological markers where clinically indicated. The correct answer is C. Relying exclusively on the patient's self-report of substance use, assuming that cognitive deficits do not significantly impact their ability to accurately recall or disclose their history. Explanation: this scenario is professionally challenging because the patient presents with a complex interplay of cognitive deficits secondary to brain injury and potential co-occurring substance use disorder. Differentiating between symptoms directly attributable to the brain injury and those related to active substance use, or a combination of both, requires a nuanced and systematic approach. The patient's potential denial or minimization of substance use, coupled with impaired insight due to the brain injury, further complicates accurate assessment. The clinician must navigate these complexities while adhering to ethical principles of patient autonomy, beneficence, and non-maleficence, as well as relevant professional guidelines for managing patients with co-occurring disorders. The correct approach represents best professional practice because it prioritizes a comprehensive, multimodal assessment that integrates objective and subjective data. This includes utilizing validated screening tools, conducting a thorough clinical interview that accounts for cognitive limitations, obtaining collateral information when appropriate and consented to, and considering objective biological markers. This systematic approach aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based practice and the recognition of the significant impact of substance use disorders on brain injury recovery and outcomes. It also respects the patient's dignity by employing sensitive and non-judgmental assessment methods, thereby fostering trust and facilitating engagement in treatment. An incorrect approach that relies solely on self-report without corroboration fails to acknowledge the potential for impaired insight or denial stemming from both the brain injury and the substance use disorder. This can lead to an underestimation of the problem and a failure to provide necessary interventions, potentially violating the principle of beneficence. Another incorrect approach that focuses exclusively on the neurological sequelae of the brain injury, neglecting the possibility of substance use, overlooks a critical factor that can significantly impede rehabilitation and increase the risk of relapse or further injury. This omission can lead to suboptimal treatment planning and a failure to address a primary driver of some presenting symptoms, potentially causing harm. An approach that uses punitive or accusatory questioning is ethically unsound, as it can alienate the patient, damage the therapeutic alliance, and lead to further concealment of substance use, thereby undermining the goal of effective treatment and violating principles of respect and dignity. Professional decision-making in such situations should involve a structured process. First, recognizing the potential for co-occurring disorders. Second, selecting and applying appropriate, validated assessment tools and techniques that are sensitive to the cognitive impairments of brain injury. Third, integrating information from multiple sources, patient, family, medical records, objective tests. Fourth, formulating a differential diagnosis that considers both brain injury and substance use disorder. And finally, developing a collaborative, individualized treatment plan that addresses both conditions concurrently. Question 9. The audit findings indicate a statistically significant increase in the prescription of a novel class of neuromodulatory agents for patients experiencing specific neurochemical dysregulation following traumatic brain injury, coinciding with a period of increased personal investment in the pharmaceutical company manufacturing these agents. As a physician specializing in brain injury medicine, what is the most ethically and professionally sound course of action? Option A. Continue prescribing the novel neuromodulatory agents as clinically indicated, but proactively disclose the personal investment to all affected patients and their families, without altering the treatment regimen. Option B. Immediately cease prescribing the novel neuromodulatory agents and switch all patients to older, more established classes of neurochemical treatments, regardless of individual patient response or specific neurochemical profiles, to avoid any perception of conflict of interest. Option C. Conduct a thorough review of the patient charts for all individuals prescribed these neuromodulatory agents, cross-referencing with their specific neurochemical profiles and documented clinical responses, and consult with colleagues specializing in neuropharmacology to ensure adherence to current evidence-based guidelines for managing post-traumatic neurochemical imbalances. Option D. Initiate a broader prescription of various neurochemical agents, including the novel class and others, to ensure comprehensive coverage of potential neurochemical deficits, thereby mitigating any appearance of preferential treatment for a specific agent. The correct answer is C. Conduct a thorough review of the patient charts for all individuals prescribed these neuromodulatory agents, cross-referencing with their specific neurochemical profiles and documented clinical responses, and consult with colleagues specializing in neuropharmacology to ensure adherence to current evidence-based guidelines for managing post-traumatic neurochemical imbalances. Explanation: this scenario presents a professional challenge due to the inherent conflict between a physician's duty to provide optimal patient care and the potential for financial gain influencing treatment decisions. The audit findings highlight a discrepancy that necessitates careful ethical and professional consideration, particularly in the context of neurochemical changes post-brain injury, where treatment options can be complex and their efficacy debated. The correct approach, which involves a thorough review of the patient's clinical data, consultation with colleagues, and adherence to established treatment guidelines for neurochemical imbalances post-brain injury, represents best professional practice. This aligns with the core ethical principles of beneficence and non-maleficence, ensuring that patient care is driven by clinical need and evidence-based medicine, not by potential financial incentives. The American Board of Psychiatry and Neurology's ethical guidelines emphasize physician integrity and the primacy of patient welfare. An incorrect approach would be to dismiss the audit findings without a comprehensive review, potentially overlooking a pattern of prescribing a specific class of neurochemical agents that may not be the most appropriate or cost-effective for the patient's condition. This failure to investigate a potential issue raised by an audit could be seen as a breach of professional responsibility and a disregard for institutional oversight mechanisms designed to ensure quality of care and fiscal responsibility. Another incorrect approach would be to immediately alter prescribing patterns based solely on the audit's implication of financial benefit from a particular agent, without a robust clinical justification. This could lead to suboptimal patient outcomes if the alternative agents are less effective or have a higher risk profile for the specific neurochemical changes observed post-injury. Such a decision would prioritize financial considerations over patient well-being, violating ethical mandates. Furthermore, an incorrect approach would be to engage in defensive medicine by overprescribing a broad spectrum of neurochemical agents without clear indication, simply to avoid scrutiny. This not only exposes the patient to unnecessary medication risks and costs, but also fails to address the specific neurochemical dysregulation effectively, demonstrating a lack of clinical judgment and adherence to evidence-based practice. The professional decision-making process in such situations should involve a systematic approach. First, understanding the nature of the audit findings and their potential implications. Second, critically evaluating the patient's clinical status and the rationale for current and proposed treatments, considering the specific neurochemical changes post-brain injury. Third, consulting with peers or specialists to gain diverse perspectives and ensure adherence to best practices and guidelines. And finally, documenting all decisions and their justifications thoroughly. This process ensures that patient care remains paramount and that all professional and ethical obligations are met. Question 10. During the evaluation of a 45-year-old male found unresponsive at the scene of a motor vehicle collision, EMS personnel note a GCS of 7, unequal pupils, and a palpable deformity of the skull. The patient is breathing spontaneously but shallowly. What is the most appropriate initial management strategy for this patient in the pre-hospital setting, adhering to established guidelines for traumatic brain injury? Option A. Immediately initiate rapid transport to the nearest hospital without further intervention, as the patient's condition appears severe. Option B. Secure the airway with a definitive airway adjunct. Administer high-flow oxygen, establish 2 large-bore intravenous lines, and administer a fluid bolus if hypotensive, while preparing for rapid transport to a trauma center. Option C. Focus on controlling any external bleeding, and then administer a sedative to facilitate intubation and further assessment. Option D. Administer a potent analgesic to alleviate potential pain and discomfort, followed by oxygen administration. Correct answer is B. Secure the airway with a definitive airway adjunct. Administer high-flow oxygen, establish 2 large-bore intravenous lines, and administer a fluid bolus if hypotensive, while preparing for rapid transport to a trauma center. Explanation. This scenario presents a common challenge in brain injury medicine: the need to rapidly assess and stabilize a patient with a suspected traumatic brain injury, TBI, in a pre-hospital setting, balancing immediate life-saving interventions with the potential for exacerbating neurological injury. The professional challenge lies in the dynamic nature of TBI, where initial presentation can be misleading and prompt. Appropriate management is critical to prevent secondary injury and optimize outcomes. The pre-hospital provider must make high-stakes decisions with limited information and resources, adhering to established protocols and guidelines. The correct approach represents best professional practice by prioritizing immediate life threats and adhering to established guidelines for TBI management. This includes ensuring airway patency, adequate oxygenation, and circulatory support, as these are fundamental to preventing secondary brain injury. Specifically, maintaining adequate cerebral perfusion pressure, CPP, by managing hypotension and hypoxia is paramount. Use of a validated TBI assessment tool, such as the Glasgow Coma Scale, GCS, an assessment for focal neurological deficits, guides further management and transport decisions. Adherence to these principles aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based practice and patient safety in neurological emergencies, as reflected in Standard Emergency Medical Services, EMS, protocols and guidelines for TBI. An incorrect approach that focuses solely on rapid transport, without addressing immediate physiological derangements, is professionally unacceptable. Failure to secure an airway or manage hypotension in a patient with suspected TBI can lead to profound secondary brain injury, including ischemic damage and increased intracranial pressure, directly contradicting the ethical obligation to provide the highest standard of care and the regulatory expectation for competent pre-hospital management. Similarly, administering medications that could potentially lower blood pressure or alter neurological status without a clear indication and understanding of their impact on TBI physiology would be a significant deviation from best practice and could worsen the patient's condition. This represents a failure to apply critical thinking and adhere to established TBI management principles, potentially violating standards of care. The professional decision-making process in such situations should involve a systematic approach. First, identify and manage immediate life threats, ABCs: airway, breathing, circulation. Second, conduct a rapid neurological assessment using standardized tools to gauge severity and identify focal deficits. Third, consider potential mechanisms of injury and associated injuries. Fourth, initiate interventions to optimize physiological parameters critical for brain health, e.g., maintaining blood pressure, oxygenation, and normothermia. Finally, ensure rapid, appropriate transport to a facility capable of definitive TBI management, communicating all findings and interventions clearly to the receiving medical team. This structured approach, guided by established protocols and clinical judgment, minimizes the risk of error and maximizes the potential for positive patient outcomes. Question 11. Operational review demonstrates that the Neurobehavioral Rating Scale, NRS, is utilized across multiple outpatient clinics within a brain injury rehabilitation network. To ensure consistent and accurate application of the NRS, which of the following represents the most appropriate strategy for maintaining high standards of practice? Option A. Allow experienced clinicians to administer the NRS based on their prior knowledge, with informal peer review occurring only when significant discrepancies in patient progress are noted. Option B. Encourage clinicians to adapt the NRS administration and scoring based on their clinical judgment and the specific needs of individual patients, documenting any deviations. Option C. Implement a mandatory annual training program for all clinicians who administer the NRS, focusing on standardized administration, scoring, and interpretation with periodic competency checks. Option D. Prioritize rapid completion of the NRS during patient evaluations to maximize the number of patients seen per day, with a focus on capturing the most salient behavioral observations. The correct answer is C. Implement a mandatory annual training program for all clinicians who administer the NRS, focusing on standardized administration, scoring, and interpretation, with periodic competency checks. Explanation. This scenario presents a common challenge in brain injury medicine, ensuring the consistent and accurate application of behavioral assessment tools across different clinical settings and by various healthcare professionals. The professional challenge lies in maintaining fidelity to the intended use of a standardized scale like the Neurobehavioral Rating Scale, NRS, while accommodating the practical realities of diverse patient populations and clinical workflows. Careful judgment is required to balance the need for standardized data collection with the imperative of providing individualized patient care. The correct approach represents best professional practice because it emphasizes the importance of ongoing education and competency validation for all clinicians utilizing the NRS. This aligns with the APBIN commitment to maintaining high standards of subspecialty practice, which inherently requires that practitioners are proficient in the tools and techniques essential for accurate diagnosis and management of brain injury. Adherence to the NRS manual's guidelines and the provision of regular training ensures that assessments are conducted reliably and validly, leading to more accurate clinical interpretations and better informed treatment plans. This proactive approach minimizes the risk of misinterpretation or inconsistent application of the scale, which could negatively impact patient outcomes and potentially lead to suboptimal care. An incorrect approach that relies solely on a single clinician's expertise without formal validation or ongoing training is professionally unacceptable. This fails to meet the implicit standard of care for using a standardized assessment tool, as it introduces a high risk of inter-rater variability and subjective bias. Ethically, it compromises the principle of beneficence by potentially leading to inaccurate assessments and thus suboptimal treatment. From a regulatory standpoint, it could be seen as a failure to adhere to best practices in neurobehavioral assessment, potentially falling short of the standards expected by accrediting bodies or professional organizations that the APBIN upholds. Another incorrect approach that involves modifying the NRS administration without explicit validation or clear justification for the modifications is also professionally unacceptable. Such deviations can invalidate the scale's psychometric properties, rendering the collected data incomparable to normative data or data collected by other clinicians adhering to the standard protocol. This undermines the scientific basis of the assessment and can lead to erroneous conclusions about a patient's behavioral status. This practice violates the principle of fidelity to established assessment methodologies, which is crucial for reliable and valid clinical decision-making. A third incorrect approach that prioritizes speed of administration over adherence to the NRS protocol is professionally unsound. While efficiency is desirable in healthcare, it must not come at the expense of assessment accuracy. The NRS is designed with specific item administration and scoring procedures that are critical for its validity. Rushing through the assessment compromises the quality of the data obtained, potentially leading to missed observations or inaccurate scoring. This can result in misdiagnosis or inappropriate treatment recommendations, directly impacting patient well-being and potentially violating the principle of non-maleficence. The professional decision-making process for similar situations should involve a commitment to continuous learning and quality improvement. When implementing or reviewing the use of standardized assessment tools, clinicians should 1. Ensure all users are adequately trained on the specific scales administration and scoring procedures, referencing the official manual. 2. Establish a system for regular competency checks or inter-rater reliability assessments, especially in multi-clinician settings. 3. Critically evaluate any proposed modifications to the standard protocol, ensuring they are evidence-based and do not compromise the scale's validity. 4. Prioritize accurate and thorough assessment over speed, recognizing that the quality of data directly influences the quality of patient care. 5. Stay abreast of updates or revisions to assessment tools and guidelines from relevant professional bodies. Question 12. Strategic planning requires a physician to anticipate and prepare for critical patient presentations. In a pre-hospital setting, a 45-year-old male presents following a fall with a witnessed loss of consciousness. On arrival of EMS, he is obtunded with a GCS of 9, unequal pupils, and a small laceration on his forehead. EMS reports a brief period of seizure activity. Given the mechanism of injury and initial presentation, what is the most appropriate immediate management protocol to initiate while awaiting transport to a level I trauma center with neurosurgical capabilities? Option A. Administer large volumes of intravenous normal saline to maintain blood pressure and provide aggressive pain management. Option B. Secure the airway with endotracheal intubation, maintain cervical spine precautions, and initiate rapid transport to the nearest trauma center. Option C. Administer intravenous opioids for pain control and monitor vital signs closely before considering transport. Option D. Focus on obtaining a detailed collateral history from bystanders and the patient's family before initiating transport. The correct answer is B. Secure the airway with endotracheal intubation, maintain cervical spine precautions, and initiate rapid transport to the nearest trauma center. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in brain injury medicine, managing a patient with a suspected acute intracranial hemorrhage in a resource-limited pre-hospital setting. The professional challenge lies in balancing the urgency of definitive care with the immediate need for stabilization, adhering to established protocols, and ensuring patient safety while awaiting advanced medical intervention. The physician must exercise careful judgment in prioritizing interventions that are evidence-based and aligned with current emergency management guidelines for traumatic brain injury, TBI. Correct approach analysis. The correct approach, which involves immediate airway management, cervical spine stabilization, and rapid transport to a trauma center with neurosurgical capabilities, represents best professional practice. This aligns with established guidelines from organizations like the American College of Surgeons Committee on Trauma (ACSCOT) and the Brain Trauma Foundation, which emphasize the golden hour for TBI patients. Prompt airway control prevents hypoxia and hypercapnia, both detrimental to injured brain tissue. Cervical spine immobilization is crucial to prevent secondary spinal cord injury. Rapid transport to a facility equipped for neurosurgical intervention is paramount for timely diagnosis, e.g., CT scan, and management of the intracranial hemorrhage. These actions are directly supported by the principles of emergency medicine and neurocritical care, aiming to minimize secondary brain injury and improve neurological outcomes, as implicitly guided by the standards of care expected within the American Board of Psychiatry and Neurology's purview for subspecialty practice. Incorrect approaches analysis. An approach that prioritizes immediate intravenous fluid resuscitation with large volumes of crystalloids without considering potential for increased intracranial pressure is professionally unacceptable. While fluid management is important, aggressive fluid resuscitation in the context of suspected elevated ICP can exacerbate cerebral edema and worsen outcomes, contrary to best practices in TBI management. This deviates from established guidelines that advocate for euvolemia and careful fluid management in TBI, an approach that delays transport to obtain a detailed neurological history from the patient or family at the scene, when the patient exhibits signs of significant neurological compromise, e.g., Glasgow Coma Scale Score 15, is professionally unsound. The urgency of the situation and the potential for rapid neurological deterioration necessitate immediate transport to definitive care. Prolonged on-scene assessment in the face of severe TBI risks missing the critical window for intervention, leading to poorer outcomes. This violates the principle of rapid assessment and transport for critically injured patients. An approach that focuses on administering pain medication without addressing immediate life threats like airway compromise or significant bleeding is professionally deficient. While pain management is important, it is a secondary concern when compared to securing the airway, controlling hemorrhage, and stabilizing the patient for transport. Prioritizing comfort over life-saving interventions in an acute TBI scenario is a failure to adhere to the fundamental principles of emergency medical care. Professional reasoning. Professionals should employ a systematic approach to emergency management, often guided by the ABDE, airway, breathing, circulation, disability, exposure assessment. In TBI, this is augmented by specific considerations for neurological status and potential for increased ICP. The decision-making process involves rapid assessment, identification of immediate life threats, initiation of critical interventions, and prompt transport to the appropriate level of care, all while adhering to established protocols and evidence-based guidelines relevant to the jurisdiction. The physician must constantly weigh the benefits of on-scene intervention against the risks of delaying definitive care. Question 13. Regulatory review indicates that obtaining a comprehensive history from a patient with a recent traumatic brain injury, TBI, requires careful consideration of the patient's altered cognitive and emotional state. Which of the following interview techniques best aligns with ethical and professional standards for assessing such patients in the United States? Option A. Prioritizing the collection of detailed information from family members and caregivers first, assuming the patient's recall will be significantly impaired. Option B. Initiating the interview with open-ended questions, allowing ample time for responses, using clear and simple language, and seeking consent before involving family members for collateral information. Option C. Presenting the patient with a list of potential diagnoses and asking them to select the one that best describes their current experience. Option D. Employing a structured, question-by-question approach, using a standardized TBI symptom checklist to ensure all potential areas are covered efficiently. The correct answer is D. Employing a structured, question-by-question approach using a standardized TBI symptom checklist to ensure all potential areas are covered efficiently. Explanation. This scenario presents a professional challenge due to the inherent complexity of obtaining a comprehensive history from a patient with a recent traumatic brain injury, TBI. The patient's cognitive and emotional state may be altered, impacting their ability to recall events accurately, communicate effectively, or provide consent for certain disclosures. The physician must balance the need for detailed information to guide diagnosis and treatment with the patient's potential vulnerability and diminished capacity. Careful judgment is required to ensure the interview is conducted ethically and effectively, respecting patient autonomy while gathering necessary clinical data. The correct approach represents best professional practice by prioritizing a patient-centered, trauma-informed interview. This involves establishing rapport, using clear and simple language, allowing ample time for responses, and employing open-ended questions to encourage detailed narratives. It acknowledges the potential for memory deficits, emotional lability, and executive dysfunction common after TBI. This approach aligns with the ethical principles of beneficence and non-maleficence, ensuring the patient's well-being is paramount. Furthermore, it respects patient autonomy by seeking consent and involving caregivers appropriately, recognizing that a patient with TBI may require support in decision-making processes, as guided by established medical ethics and patient rights frameworks within the United States. An incorrect approach that focuses solely on a rapid, checklist-style interview fails to account for the cognitive sequelae of TBI. This approach risks missing crucial subjective experiences and functional impairments, leading to an incomplete or inaccurate assessment. Ethically, it can be seen as a failure of beneficence, as it may not adequately identify the patient's needs. It also risks violating patient dignity by treating them as a collection of symptoms rather than an individual with a complex experience. Another incorrect approach that involves extensively questioning family members or caregivers without the patient's explicit consent, or without clearly explaining the purpose and scope of the information sought, raises significant privacy concerns. This can violate patient confidentiality and autonomy, particularly if the patient has some capacity to understand and consent. While collateral information is often vital, it must be obtained ethically and transparently, respecting the patient's rights as outlined in U.S. healthcare regulations. A third incorrect approach that involves making definitive diagnostic statements or offering prognoses early in the interview before a thorough assessment is premature and potentially harmful. This can create false expectations, increase patient anxiety, and undermine the physician-patient relationship. It represents a failure of professional judgment and can be ethically problematic by not adhering to the principle of providing accurate and evidence-based information. The professional decision-making process for similar situations should involve a systematic approach. First, assess the patient's current level of cognitive and emotional functioning to determine their capacity for interview participation and consent. Second, establish a safe and supportive environment, building rapport and trust. Third, employ flexible and adaptive interviewing techniques, tailoring questions and pace to the patient's responses. Fourth, judiciously incorporate collateral information, ensuring ethical consent and transparency. Finally, document the interview process thoroughly, including any challenges encountered and the rationale for the chosen approach. Question 14. The evaluation methodology shows that current community reintegration programs for individuals with brain injuries are experiencing suboptimal outcomes in terms of long-term social engagement and independent living. Considering the regulatory framework for rehabilitation services and ethical guidelines for patient care, which of the following approaches would best optimize these programs? Option A. Relying on a single therapist to manage all aspects of community reintegration, assuming a comprehensive understanding of the patient's needs without external consultation. Option B. Implementing a standardized, group-based vocational training module that focuses on job placement as the primary measure of success. Option C. Prioritizing the reduction of program costs by limiting the duration and scope of therapeutic interventions to those deemed essential for basic functional recovery. Option D. Developing individualized, multidisciplinary care plans that incorporate cognitive, emotional, social, and vocational support, with regular reassessment and adaptation based on patient progress and community resource availability. The correct answer is B. Implementing a standardized, group-based vocational training module that focuses on job placement as the primary measure of success. Explanation. The evaluation methodology shows a need to optimize community reintegration programs for individuals with brain injuries. This scenario is professionally challenging because effective reintegration requires a nuanced understanding of individual needs, community resources, and the dynamic nature of recovery, all while adhering to established ethical and regulatory standards for patient care and program efficacy. Balancing patient autonomy with the need for structured support and ensuring equitable access to resources are critical considerations. The correct approach represents best professional practice because it prioritizes a multidisciplinary, individualized, and evidence-based strategy. This aligns with the core principles of brain injury rehabilitation, emphasizing functional recovery, social participation, and quality of life. Regulatory frameworks, such as those guiding rehabilitation services and patient rights, mandate personalized care plans that are regularly reviewed and adapted. Ethical guidelines further underscore the importance of patient-centered care, informed consent, and the promotion of independence. This approach ensures that programs are not only effective in addressing the cognitive, emotional, and physical sequelae of brain injury, but also respect the individual's goals and aspirations for community life. An incorrect approach that focuses solely on vocational rehabilitation without addressing broader psychosocial needs fails to meet regulatory requirements for comprehensive care. Such a narrow focus neglects the multifaceted impact of brain injury on an individual's ability to engage in their community, potentially leading to social isolation and reduced quality of life, which is contrary to the goals of rehabilitation. Another incorrect approach that relies on a one-size-fits-all program design ignores the critical need for individualized assessment and intervention, a cornerstone of ethical practice and regulatory compliance in healthcare. This can lead to ineffective or even detrimental outcomes for patients with diverse injury profiles and support needs. A third incorrect approach that prioritizes cost-effectiveness over patient outcomes would violate ethical obligations to provide the highest standard of care and could contravene regulations that mandate evidence-based practices and patient well-being as primary objectives. Professional decision-making in similar situations requires a systematic process. First, thoroughly assess the individual's current functional status, cognitive abilities, psychosocial needs, and personal goals. Second, consult relevant clinical guidelines and regulatory frameworks governing brain injury rehabilitation and community reintegration. Third, engage a multidisciplinary team, including the patient, family, physicians, therapists, and social workers, to collaboratively develop a personalized reintegration plan. Fourth, implement the plan, continuously monitor progress, and adapt interventions based on ongoing assessment and feedback, ensuring that all decisions are ethically sound and compliant with applicable regulations. Question 15. Compliance review shows that following a patient's severe traumatic brain injury, the attending neurologist independently initiated a plan for aggressive medical management and early mobilization protocols, without convening a formal meeting with the rehabilitation team, including physical therapy, occupational therapy, and speech-language pathology, to discuss the patient's overall acute care trajectory and potential rehabilitation needs. Which of the following represents the most appropriate and compliant approach to managing this patient's acute care phase? Option A. Request that each individual specialist submit their proposed interventions in writing to the neurologist, who will then synthesize these into a single, overarching plan. Option B. Delegate the responsibility for coordinating the multidisciplinary approach to the bedside nurse, who can then relay information between the neurologist and the rehabilitation team as needed. Option C. Proceed with the neurologist's independently developed plan, as their expertise is primary in acute neurological management, and involve the rehabilitation team only when the patient is medically stable for transfer to a rehabilitation unit. Option D. Immediately convene a multidisciplinary team meeting involving neurology, rehabilitation specialists, nursing, and case management to collaboratively develop and refine the acute care plan, ensuring integrated goals for medical stabilization and early functional intervention. Correct answer is D. Immediately convene a multidisciplinary team meeting involving neurology, rehabilitation specialists, nursing, and case management to collaboratively develop and refine the acute care plan, ensuring integrated goals for medical stabilization and early functional intervention. Explanation. This scenario presents a professional challenge due to the inherent complexity of acute brain injury management, which demands rapid, coordinated, and comprehensive care. The critical nature of the patient's condition necessitates immediate and effective communication and collaboration among diverse specialists to optimize outcomes and prevent secondary injury. The challenge lies in ensuring that all team members, despite their varied expertise and perspectives, are aligned on the patient's immediate goals and long-term trajectory, adhering to established best practices and regulatory guidelines for acute neurological care. The correct approach represents best professional practice because it prioritizes a structured, integrated, and patient-centered multidisciplinary team meeting. This aligns with the American Board of Psychiatry and Neurology's emphasis on evidence-based practice and collaborative care models, as outlined in their subspecialty guidelines for brain injury medicine. Specifically, it reflects the expectation that neurologists, physiatrists, nurses, therapists, and social workers will actively participate in shared decision-making, contributing their unique insights to develop a unified treatment plan. This collaborative process ensures that all aspects of the patient's recovery, from medical stabilization to early rehabilitation planning and psychosocial support, are addressed concurrently and efficiently, minimizing delays and potential gaps in care. Adherence to these collaborative principles is implicitly mandated by the APBAN focus on comprehensive patient management. An incorrect approach that fails to convene the core multidisciplinary team for a joint discussion of the patient's acute management plan is professionally unacceptable. This failure represents a significant regulatory and ethical lapse. It violates the principle of coordinated care, which is fundamental to managing complex neurological conditions. Such an approach could lead to fragmented care, conflicting treatment strategies, and a lack of shared understanding among caregivers, potentially jeopardizing patient safety and outcomes. Ethically, it falls short of the duty to provide comprehensive and integrated care, as expected by professional boards and regulatory bodies overseeing medical practice. Furthermore, it may contravene guidelines that emphasize the importance of interdisciplinary communication in preventing adverse events and ensuring optimal patient trajectories in acute settings. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's immediate needs and the identification of all relevant specialists. The core principle is to establish a clear communication channel and a forum for shared decision-making. This involves proactively scheduling regular team conferences, even in the acute phase, to discuss progress, adjust interventions, and set short-term goals. Professionals should be trained to recognize the value of each team member's contribution and to facilitate open dialogue. When faced with a complex acute brain injury, the default should be to engage the multidisciplinary team, rather than to proceed with isolated decision-making. This proactive, collaborative stance is the cornerstone of effective acute care for brain injury patients. Question 16. Implementation of neuroimaging for a 45-year-old male presenting to the emergency department with altered mental status and a history of a witnessed fall from standing height, with no loss of consciousness reported but with scalp lacerations and a palpable frontal bone deformity, requires careful consideration of diagnostic modalities. Which of the following imaging strategies best aligns with established protocols for initial assessment in this acute traumatic brain injury scenario? Option A. Immediate magnetic resonance imaging, MRI of the brain to obtain detailed anatomical information of brain parenchyma and vasculature. Option B. Clinical observation alone, deferring imaging until neurological status significantly deteriorates. Option C. Positron emission tomography, PET, scan of the brain to evaluate metabolic activity and identify areas of neuronal dysfunction. Option D. Computed tomography, CT, scan of the head to rapidly assess for acute intracranial hemorrhage, mass effect, and bony abnormalities. The correct answer is A. Immediate magnetic resonance imaging, MRI, of the brain to obtain detailed anatomical information of brain parenchyma and vasculature. Explanation. This scenario presents a common challenge in brain injury medicine, selecting the most appropriate neuroimaging modality to assess a patient with acute neurological deficits following trauma. The professional challenge lies in balancing the need for rapid diagnosis, the potential risks and benefits of each imaging technique, and the specific clinical context of the patient. Careful judgment is required to avoid unnecessary radiation exposure, optimize diagnostic yield, and ensure timely and effective management. The correct approach represents best professional practice by prioritizing a rapid, widely available, and sensitive modality for detecting acute intracranial hemorrhage and bony abnormalities, which are common and critical findings in traumatic brain injury. This aligns with established clinical guidelines and the regulatory framework for emergency medical care, which emphasizes prompt assessment and management of life-threatening conditions. The use of CT is generally favored in the acute setting due to its speed, availability, and efficacy in identifying acute bleeds, fractures, and mass effect, thereby guiding immediate surgical or medical interventions. An incorrect approach would be to immediately opt for MRI without a clear indication for its superior soft tissue contrast in the acute traumatic setting. While MRI offers greater detail of brain parenchyma, it is time-consuming, less readily available in emergent situations, and poses contraindications, e.g., metallic implants. This delay in diagnosis and management could lead to adverse patient outcomes, potentially violating the duty of care and established standards of practice. Another incorrect approach would be to rely solely on clinical examination without imaging in the presence of significant trauma and neurological deficits, as subtle but critical injuries may be missed, leading to delayed or inappropriate treatment. This failure to utilize available diagnostic tools when indicated could be considered a breach of professional standards. Professionals should employ a decision-making framework that begins with a thorough clinical assessment, including the mechanism of injury, neurological status, and presence of focal deficits. This assessment should then guide the selection of the most appropriate initial imaging modality, considering factors such as speed of acquisition, availability, sensitivity for specific pathologies, and patient safety. In acute trauma, CT is typically the first-line modality for evaluating intracranial injury. If CT is equivocal or if specific soft tissue abnormalities are suspected that CT cannot adequately visualize, then MRI may be considered as a subsequent step, provided the patient's condition and logistical factors permit. Question 17. Operational review demonstrates a 45-year-old male with a history of moderate traumatic brain injury, TBI, sustained 18 months ago, presenting with persistent executive dysfunction, emotional lability, and significant sleep disturbances. He has no prior psychiatric history. The patient's primary care physician has initiated treatment for presumed major depressive disorder based on his low mood and anhedonia. Which of the following diagnostic approaches is most critical for ensuring an accurate differential diagnosis in this complex presentation? Option A. A trial of antidepressant medication with close monitoring for symptom improvement, assuming the symptoms are a direct manifestation of post-TBI depression. Option B. A comprehensive neurocognitive assessment to objectively evaluate executive functions, memory, attention, and processing speed, alongside a detailed review of the TBI's impact on brain regions associated with mood and behavior. Option C. A detailed review of the patient's social history and current stressors to identify environmental factors contributing to his symptoms. Option D. A referral to a psychiatrist for a formal psychiatric evaluation, focusing exclusively on criteria for mood disorders and anxiety. Correct answer is B. A comprehensive neurocognitive assessment to objectively evaluate executive functions, memory, attention, and processing speed, alongside a detailed review of the TBI's impact on brain regions associated with mood and behavior. Explanation. Scenario analysis. This scenario is professionally challenging because the patient presents with a constellation of symptoms that can overlap significantly between primary psychiatric disorders and neurocognitive deficits secondary to brain injury. The risk of misdiagnosis is high, potentially leading to inappropriate treatment, delayed recovery, and adverse patient outcomes. The clinician must navigate the complexities of differentiating between conditions that may mimic each other, requiring a thorough and systematic diagnostic process grounded in established medical principles and regulatory guidelines for patient care. Correct approach analysis. The correct approach involves a comprehensive differential diagnosis that systematically considers and rules out brain injury-related conditions. This aligns with best professional practice as mandated by the American Board of Psychiatry and Neurology, APN, guidelines for the subspecialty in brain injury medicine, which emphasize a thorough evaluation of potential organic etiologies for neurological and psychiatric symptoms. This approach ensures that all plausible causes are investigated, leading to an accurate diagnosis and appropriate management plan, thereby upholding the ethical obligation to provide competent and evidence-based care. Incorrect approaches analysis. One incorrect approach would be to solely focus on a primary psychiatric diagnosis without adequately investigating potential neurological causes. This fails to meet the standard of care by neglecting the possibility of a treatable organic condition, potentially violating ethical principles of beneficence and non-maleficence. It also disregards the APN emphasis on a broad differential diagnosis in brain injury medicine. Another incorrect approach would be to prematurely attribute all symptoms to a known psychiatric condition, without a detailed neurocognitive assessment or consideration of the patient's injury history. This demonstrates a lack of due diligence and can lead to misattribution of symptoms, hindering effective treatment and potentially causing harm by overlooking the underlying brain injury. A third incorrect approach would be to rely solely on subjective patient reporting without objective clinical findings or diagnostic testing to support a specific diagnosis. This is insufficient for complex differential diagnoses, particularly when organic etiologies are suspected, and does not adhere to the rigorous diagnostic standards expected in subspecialty practice. Professional reasoning. Professionals should employ a structured diagnostic framework. This begins with a detailed history, including the mechanism and severity of any known brain injury, pre-injury functioning, and a comprehensive review of current symptoms. This is followed by a thorough physical and neurological examination, including a detailed mental status examination. Crucially, a neurocognitive assessment is essential to identify specific deficits. Imaging studies, e.g., MRI, CT, and other investigations, e.g., Laboratory tests should be considered based on the clinical presentation to rule out or confirm structural or functional abnormalities. The process involves iterative hypothesis testing, where initial findings inform further investigation until a definitive or most likely diagnosis is established, guiding subsequent treatment and management. Question 18. Stakeholder feedback indicates a need for clearer guidance on optimizing neuroplasticity and recovery mechanisms in patients with moderate to severe traumatic brain injury. Considering the current understanding of neurobiological processes underlying recovery, which of the following therapeutic strategies would be most aligned with promoting significant functional gains? Option A. Primarily relying on passive physical modalities such as heat and electrical stimulation to promote tissue healing and reduce inflammation, with minimal emphasis on active patient participation. Option B. Administering high-dose, unproven experimental supplements purported to regenerate neural tissue without robust clinical trial data supporting their efficacy in neuroplasticity. Option C. Focusing exclusively on pharmacological interventions aimed at symptom management, such as pain and spasticity, without incorporating active rehabilitation or strategies to directly enhance neural rewiring. Option D. A combination of pharmacotherapy designed to enhance synaptic plasticity and neurotransmission, coupled with intensive, task-specific rehabilitation, exercises targeting impaired motor and cognitive functions. The correct answer is D. A combination of pharmacotherapy designed to enhance synaptic plasticity and neurotransmission, coupled with intensive, task-specific rehabilitation exercises targeting impaired motor and cognitive functions. Explanation: this scenario presents a professional challenge due to the inherent variability in neuroplasticity and recovery trajectories following brain injury. Clinicians must balance evidence-based interventions with individualized patient needs, recognizing that no two recovery paths are identical. The pressure to demonstrate progress, coupled with patient and family expectations, necessitates a nuanced approach to treatment planning and communication. Careful judgment is required to avoid overpromising or underestimating the potential for recovery, ensuring that interventions are both appropriate and ethically sound within the scope of practice. A correct approach represents best professional practice by emphasizing a comprehensive, multimodal strategy that directly targets known mechanisms of neuroplasticity. This aligns with the American Board of Psychiatry and Neurology's commitment to evidence-based medicine and patient-centered care. By integrating pharmacotherapy aimed at modulating neurotransmitter systems involved in synaptic plasticity, e.g., enhancing glutamate or acetylcholine signaling, alongside structured rehabilitation targeting motor and cognitive relearning through repetitive, task-specific practice, the clinician is leveraging established principles of neuroplasticity. This approach is ethically justified as it maximizes the potential for functional recovery by addressing both biological and behavioral aspects of brain repair, adhering to the principle of beneficence. Furthermore, it respects patient autonomy by involving them in goal setting and treatment selection. An incorrect approach that focuses solely on passive therapies without active engagement in rehabilitation fails to capitalize on the principles of experience-dependent plasticity. This is ethically problematic as it may represent a failure to provide the most effective interventions available, potentially leading to suboptimal outcomes and violating the duty of care. It also risks mismanaging patient expectations by implying that passive modalities alone can drive significant recovery, which is not supported by current understanding of neuroplasticity. Another incorrect approach that relies exclusively on unproven or experimental interventions without a strong scientific rationale for their impact on neuroplasticity is professionally unacceptable. This could lead to wasted resources, potential harm, and a breach of ethical obligations to provide evidence-based care. It also undermines the credibility of the profession and may expose patients to exploitation. The professional decision-making process for similar situations should involve a thorough assessment of the patient's injury, functional deficits, and personal goals. This should be followed by a critical review of the current scientific literature on neuroplasticity and recovery mechanisms relevant to the specific injury. Clinicians should then formulate a treatment plan that integrates evidence-based interventions, including pharmacotherapy and rehabilitation, tailored to the individual. Regular reassessment of progress and adaptation of the treatment plan based on the patient's response are crucial. Open and honest communication with the patient and their family regarding realistic expectations and the rationale behind treatment choices is paramount. Question 19. The control framework reveals that patient presents with persistent cognitive and behavioral difficulties 5 years after a traumatic brain injury. While initial assessments documented diffuse axonal injury, current clinical presentation suggests a decline in executive function and increased emotional lability. To best characterize the ongoing impact of the brain injury on the patient's brain structure and function, which of the following approaches is most aligned with current best practices in brain injury medicine? Option A. Conduct a comprehensive neuroimaging study, including advanced MRI sequences to assess white matter integrity and volumetric changes, alongside a detailed neuropsychological battery to evaluate executive functions, memory, and processing speed. Option B. Rely primarily on the patient's subjective report of cognitive and emotional changes, cross-referenced with initial injury documentation. Option C. Review the initial discharge summary and consult with the patient's primary care physician for an overview of their general health status. Option D. Focus solely on managing the current behavioral symptoms with psychotropic medications, assuming structural changes are static. The correct answer is A. Conduct a comprehensive neuroimaging study, including advanced MRI sequences to assess white matter integrity and volumetric changes, alongside a detailed neuropsychological battery to evaluate executive functions, memory, and processing speed. Explanation. The control framework reveals that managing patients with long-term effects of brain injury requires a nuanced understanding of neuroplasticity, neurogeneration, and the interplay between structural changes and functional deficits. This scenario is professionally challenging because the long-term consequences of brain injury are often progressive, multifactorial, and can manifest years after the initial insult, impacting cognitive, emotional, and physical domains. Accurate assessment and management necessitate a longitudinal perspective, considering not only the immediate sequelae, but also the evolving structural and functional landscape of the brain. The correct approach emphasizes a comprehensive, interdisciplinary assessment that integrates advanced neuroimaging techniques with detailed neuropsychological evaluations and functional outcome measures. This approach aligns with the APBIN commitment to evidence-based practice and the highest standards of patient care in brain injury medicine. By focusing on objective measures of structural integrity e.g., MRI for atrophy, white matter integrity, and functional capacity, e.g., standardized cognitive testing, functional independence measures, clinicians can develop personalized, evidence-informed treatment plans that address the specific long-term deficits and optimize recovery potential. This adheres to the ethical imperative of providing competent and comprehensive care, grounded in the latest scientific understanding of brain injury. An incorrect approach that relies solely on historical clinical notes, without current objective assessment, fails to acknowledge the dynamic nature of long-term brain injury effects. This neglects the professional responsibility to provide up-to-date care and may lead to misdiagnosis or suboptimal treatment strategies, potentially violating standards of care. Another incorrect approach that focuses only on symptomatic management without investigating underlying structural or functional changes overlooks the root causes of persistent deficits. This can result in a failure to identify treatable underlying processes or to implement interventions that could promote neuroplasticity or mitigate further decline, thus not meeting the comprehensive care expectations for brain injury medicine. An approach that prioritizes patient self-report over objective findings, while important, can be misleading in the context of brain injury where insight and self-awareness may be impaired. This can lead to an incomplete or inaccurate understanding of the patient's true functional status and needs. Professional decision-making in such cases requires a systematic process. 1. Acknowledge the complexity and chronicity of brain injury. 2. Gather comprehensive data, including current neuroimaging, neuropsychological testing, and functional assessments. 3. Synthesize this data to identify specific structural and functional deficits. 4. Develop a multidisciplinary treatment plan tailored to these identified deficits, considering potential for neuroplasticity and progression. 5. Regularly reevaluate and adjust the plan based on ongoing assessment and patient response. Question 20. Investigation of the most appropriate occupational therapy intervention for a patient with moderate TBI, presenting with significant executive dysfunction, impaired fine motor control in the dominant hand, and mild visual neglect, requires careful consideration of best practices. Which of the following approaches best reflects the current standards of care for occupational therapy and brain injury rehabilitation? Option A. Implementing a structured program of cognitive rehabilitation exercises targeting executive functions, coupled with task-specific training for activities of daily living, ADL, that incorporates strategies to manage visual neglect and graded exercises to improve fine motor dexterity. Option B. Focusing exclusively on compensatory strategies for executive dysfunction, such as using external memory aids and checklists, without addressing the underlying cognitive deficits or motor impairments. Option C. Recommending a series of unproven, novel sensory integration techniques based on anecdotal reports of success in other neurological conditions, without a clear rationale for their application to this patient's specific deficits. Option D. Prioritizing interventions that are most convenient for the clinic to deliver, regardless of their direct relevance to the patient's identified functional limitations or their evidence base. The correct answer is A. Implementing a structured program of cognitive rehabilitation exercises targeting executive functions, coupled with task-specific training for activities of daily living ADL, that incorporates strategies to manage visual neglect and graded exercises to improve fine motor dexterity. Explanation. Scenario analysis. This scenario presents a common challenge in brain injury medicine, determining the most effective and evidence-based occupational therapy intervention for a patient with complex cognitive and physical deficits following a traumatic brain injury, TBI. The challenge lies in balancing the patient's immediate functional needs with long-term recovery goals, while adhering to established best practices and regulatory guidelines for rehabilitation. The physician must critically evaluate proposed interventions to ensure they are not only appropriate for the patient's condition, but also align with the standards of care expected by the American Board of Psychiatry and Neurology, APN, for subspecialty practice in brain injury medicine. Correct approach analysis. The correct approach emphasizes a comprehensive, individualized assessment that forms the foundation for evidence-based intervention. This aligns with the APN expectation that subspecialists in brain injury medicine utilize a systematic and data-driven approach to patient care. Occupational therapy interventions must be tailored to the specific cognitive, physical, and psychosocial impairments identified through this thorough evaluation. The focus on functional outcomes, patient-centered goals, and integration with the interdisciplinary team reflects best practices in neurorehabilitation, ensuring that interventions are meaningful and promote optimal recovery within the patient's capacity. This approach is ethically sound as it prioritizes patient well-being and maximizes the potential for functional independence, adhering to the principles of beneficence and non-maleficence. Incorrect approach is analysis, an approach that solely focuses on compensatory strategies without addressing underlying deficits fails to meet the comprehensive rehabilitation standards expected in brain injury medicine. While compensatory strategies can be valuable, neglecting to assess and target remediable impairments can lead to suboptimal long-term outcomes and may not fully align with the goal of maximizing functional recovery. This could be seen as a failure to provide the most appropriate and potentially restorative care. An approach that prioritizes interventions based on anecdotal evidence or personal preference, rather than established research and clinical guidelines, represents a significant departure from best professional practice. The APN expects its subspecialists to be grounded in evidence-based medicine. Relying on non-validated methods or unproven techniques could lead to ineffective treatment, wasted resources, and potentially harm to the patient, violating the principle of non-maleficence. An approach that neglects to involve the patient and their family in goal setting and intervention planning is ethically problematic. Patient-centered care is a cornerstone of modern rehabilitation. Failing to obtain informed consent and collaborative input can undermine patient autonomy and adherence to treatment, potentially leading to dissatisfaction and poorer outcomes. This approach fails to respect the patient's right to participate in their own care decisions. Professional reasoning. Professionals should approach this situation by first conducting a thorough, multifaceted assessment of the patient's current functional status, cognitive abilities, physical impairments, and psychosocial needs. This assessment should be guided by evidence-based tools and clinical reasoning specific to brain injury. Following the assessment, the professional should collaborate with the patient and their family to establish realistic, patient-centered goals. Interventions should then be selected based on their evidence base for addressing the identified deficits and achieving the established goals. Regular reevaluation of progress and adaptation of the intervention plan are crucial components of effective neurorehabilitation. This systematic, evidence-based, and collaborative approach ensures that interventions are appropriate, effective, and ethically sound, meeting the high standards of the APBIN.